My name is Dr. Eugene Tuishime. I'm Associate Program Director for Research in the Anesthesia, Critical Care, and Emergency Medicine Department at the University of Rwanda. Thank you for inviting me to present in this conference. The title of my talk is Equity in Global Anesthesia and Surgery. I don't have any conflict of interest to disclose. For the outline of this talk, first, we will review the key concepts in global health. We will look on the problems of inequities in global anesthesia and surgery. We'll provide some solutions and also look on the way forward. Let's start with the definition. What is global health? Global health is defined as an area for study, research, and practice that places a priority on improving health and achieving health equity for all people worldwide. It can also be defined as a collaborative transnational research and action for promoting health for all. You can see in both definitions that we need to promote equity and health for all. What is health equity? Health equity is also defined as absence of unfair, avoidable, and remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other dimensions of inequality. Examples include sex, gender, ethnicity, disability, and sexual orientations. Let's put them together and define what is global health equity. This definition defines global health equity as a mutually beneficial and power-balanced partnerships and processes leading to equitable human and environmental health products on a global scale. Let's give an example for better understanding how the situation is and what should be done. Let's take an example of COVID-19 vaccines. For example, Canada secured at least 9 doses of vaccines for its population before even low-income countries had any vaccine at all. That shows the current situation in the global health practice. And I think we still have a long way to go if we are going to achieve global health equity. Let's also review some structural and social determinants of health, which really have a huge impact on global health equity. At structural level, we may think about the government practices, macroeconomics policies on the left, social policies about labor, housing, the market, the land, public policies like education, healthcare, social protection, and culture and values. All of those are difficult to change at an individual level. And then we can look on some other socioeconomic position which may be improved by education, the occupation we have, and the income, all of those having an impact on our health. There are also some intermediary determinants, including access to our living conditions, food, behavior, other biological factors, and the psychosocial factors. All put together will impact equity in health and well-being. Let's keep this framework in mind as we analyze the problem and the potential solutions for inequity in global surgery. Another concept which is important is decolonizing global health. There are on the left some examples of colonial remnant in global health, starting by the norms that the developing world is incapable of solving its own health problem. So this is the view of the colonial mindset. But if we can decolonize that, we may be able to think about a change in the paradigm where we believe that through continuous economic and the social development, the developing world can solve its own health problems. And we can achieve that where there is multilateralism and more power by the global south, and also shared prosperity globally. We have to keep in mind some guiding principles, including peace, development, human rights, and justice. And as we move towards a multipolar global health governance structure. And we remember that there were already practices that further strengthen an equal power hierarchy. But in this decolonized global health, we should be seeking for building a consensus to remove practices for colonial remnant. So let's keep this in mind as well. The last concept I think we should think about is successful partnerships in global health. There are a few core concepts to achieve successful partnerships, including at the operational level. We need to think about resolution, leadership, and communication. But also in our relations, we need to think about what are our main focus, what are the values that we share. Are we thinking about equity? And are we sharing the benefit from our programs? And in our outcomes, we need to think about increasing capacity, local capacity, which will lead to sustainability, and then influence our practice and also increase access to services. And if that is done, we have more chance to have successful partnerships in the global health. This slide helps us to define those core concepts. For example, for focus, they mean to have a common goal and also common interest. And for values, we have to have trust. I think trust is important for success. And also equity, where we have to recognize everyone's contribution and also share resources as much as possible. And also we need to share the benefit as well, coming from those partnerships and the knowledge exchange, and have an open and transparent communication, which will lead to success. And for the leadership and the resolutions, these two concepts have been forgotten for many partnerships, but they are essential for sustainability. And for leadership, we need to think about how to include people from both parties in decision making, and also have a process in place on how to solve conflict. Now let's go back to global surgery. What is the problem in inequity in global surgery and anesthesia? We know that 5 billion people lack access to safe, affordable surgical and anesthesia care when needed. And every year, 143 million additional surgical procedures are needed in order to save lives and prevent disability. And we know that every year, 33 million people face catastrophic health expenditure due to payment for surgery and anesthesia each year. Despite all of those needs, we know that investment in the surgery and anesthesia services is affordable, saves lives, and promotes economic growth. Lastly, we know that surgery is an indivisible, indispensable part of healthcare. Another example of inequity is the distribution of global anesthesia workforce. If we look on this map, we see that sub-Saharan Africa is is really behind in the number of anesthesia providers, where they have below one anesthesiologist per 100,000 people, which is very low in comparison to high-income countries like US or Canada, where they have between 15 and 20 anesthesiologists per 100 people. And it's almost similar if we combine the surgical workforce with surgeons and obstetricians and anesthesiologists. Still, you can see that sub-Saharan Africa is also has the lowest number, but the number of surgeons and obstetricians may be a little bit higher in comparison to anesthesiologist numbers. So we can see that in sub-Saharan Africa, we still have below one in some of the countries, and then between 1 and 14 per 100 population for surgical workforce. There is still a long way to go if we need to achieve equity in access to the specialists in surgery and anesthesia and obstetrics. Let us look also on inequities in health spending. If we look on health spending per capita in 1995, we can see also that most of sub-Saharan Africa had a spending between $5 to $118 per 100,000 per capita. But this is really very low in comparison to high-income countries, where the spending range between $2,400 to $15,800 per capita. And if we look on, even in 2016, after 11 years, there's no big change for sub-Saharan Africa. However, there is some improvement in some parts of Asia, an increase in health spending. Even the projected health spending in 2030, again, for sub-Saharan Africa, most of the countries will have spending less than $118 per capita, which is still very low. And if we do business as usual, we may even reach by 2050 with the similar inequities, and where sub-Saharan Africa will have a very low health spending per capita below $118. But there is some improvement in Asia and also South America, where the spending is above $892 in most of the countries. We need to think, why is this happening and what can be done to improve that? But most of these countries face development challenges, security issues, and also they faced problems with colonialism and the neo-colonialism. So if we put those problems in mind, we need to find a better way to improve the situation if we are going to achieve equity in global health. The last problem is the current model of global health funding. As you can see, there is a vertical program where high-income countries provide assistance to low-income countries, mainly from US and UK governments and other philanthropic organizations. And the channel by where the money is sent to low-income countries mainly include also US and UK bilateral agreement, and then the WHO and other US NGOs and they get foundations. This graph also shows how global health funding is provided depending on the area. So as we can see, most of the funding is given for HIV, TB, and malaria in a vertical model. And I don't think there's enough funding for health system strengthening. This graph shows us that in order to have enough health spending, the country GDP has to increase at least to 10,000 US dollars per capita. So that's why if we can help countries to be developed, then we can have enough funding for healthcare. Now that we understand the problem, what is the solution? First, I think we need to find ways to decolonize global health, where we can use the four guiding principles of peace, development, human rights, and justice, and also understand that low-income countries can develop themselves and solve their own problems through continuous economic and social development. And also in a multipolar world where the global south has are available on the table for decision making. And lastly, we need to understand that globally we have a shared prosperity. Second, we need to shift our funding model from funding vertical programs to investment in healthcare systems so that we can build sustainability for those programs. Third, I think we need to provide investment for sustainable development goals, especially that global surgery can improve most of those sustainable development goals, including decreasing poverty, improving good health and well-being, promoting gender equality, providing decent work and economic growth, and also reducing inequalities. Now let's think about how big is the funding that we are requesting. For example, in order to achieve the 2030 Lancet Commission on Global Surgery, we need to be able to provide about 350 billion US dollars by 2030. That's about 23 billion US dollars per year for these programs. But this is very expensive program in comparison to Gavi, for example, which has been able to secure about $19 billion since 2000. That's about 2.9 billion each year. If we compare to Global Fund, again, we need 5 times more the funding of Global Fund. So it's an expensive program. We need to find innovative way to fund this program. But also the saving is huge because there's a potential to save 12 trillion ROS and also provide about 148 million more procedures each year. Another point I want to make is how equipment in the supplies for surgery and anesthesia are still expensive in low-income countries. But there are some models which have shown to be to reduce the cost of other medical supplies, especially through Gavi. The cost of vaccines has decreased considerably. where a vaccine costing about $1,000 in the US can just be purchased in low-income countries at about $28. And also, some companies have opened manufacturing plants in low-income countries for vaccines. I think those innovative approaches can be also used for global surgery and anesthesia. This brings us to the next question about who has the capacity to fund the 2030 Lancet Commission on Global Surgery Targets. As we have seen in the previous slides, the US government and other high-income countries working with low and middle-income countries may have the capacity to provide the necessary funding. We need also to keep in mind multinational organizations, including the UN, the WHO, and the World Bank, and the Bill and Melinda Gates Foundation, and other international philanthropic organizations. There are other financing options we need to consider locally to fund the National Surgical and Obstetric and Anesthesia Plan. First, expansion of the health insurance by making it mandatory and including the surgical care, and also zero copay for retirees. We need to include public-private partnerships, and also before we start those programs, we have to use a pilot implementation plan in order to have a sustainable program. We need to consider taxations on luxury or alcohol and tobacco, telecommunication tax, or health tax from industry, and also we need regional investment. How are we going to achieve this successfully? We need to follow best practices as proposed by Quinn and colleagues by first having a capacity for international lobbying, national and local buy-in, investing in the National Surgical Obstetric and Anesthesia Plan. And once we do that, we'll be able to provide a decentralization of surgical services, increase the workforce, and have a way to have a standardized surgical data collection and implement quality improvement mechanisms for surgical systems. And lastly, we need community engagement. Again, I think it's important to measure the progress. We have the 2030 Lancet Commission on Global Surgery Targets we can use as a framework to measure the progress. Are we making really any progress? As you can see, most of African countries, they started working on the National Surgical Obstetric Anesthesia Plan, including Rwanda, Tanzania, Zambia, Madagascar, Ethiopia, Nigeria, and Senegal. But again, the baseline is still low, and we have a long way to go. If we take an example of Tanzania, for example, they have about 25 per 100,000 population surgical workforce, and they are providing about 484 surgical procedures per 100,000 population, and about 65% of the population, they still face catastrophic expenditure, and also 85% of people, they are at risk of impoverishment for surgical care. So there is still a long way to go. And In terms of workforce development, again, if we take an example of Rwanda, for example, in 2019, Rwanda had about 213 surgical anesthesia and obstetric specialists. And by 2030, there is a need of about 3,000 surgical workforce, which is really a huge task, working on the current training model, where I think we may be able to train around 1,000. So we need to find innovative ways to use also non-specialists, especially non-physician anesthetists, if we're going to achieve these targets. What is the way forward? I think we need to create a dedicated committee for advocacy at all levels, from the WFSA, professional societies, academic institutions, and the hospitals. We need to align our agenda with major stakeholders with similar interests, like the WHO, the UN, the US and the UK government, and also low and middle income countries, and also philanthropic organizations. We need to conduct a coordinated effort towards the 2030 targets, where I think we need to find one coordinating body and a mechanism for a single data collection platform. Lastly, we need to decolonize global health and ensure that all regions are equally represented at the negotiation table. Thank you very much. For questions, you can contact me at my email at tuishime36@gmail.com. Thank you.